We are going to place ECG leads on a sedated patient. Our black clip goes in the axillary in the left forelimb, directly behind the elbow. Our red clip goes onto the hind limb or the flank area on the left side. And our white lead goes in the axillary area just behind the elbow on the right forelimb. We then need to place a conductive agent between the lead and the patient. You can either use electrode gel, ultrasound gel, or old-fashioned alcohol. This patient has been sedated with dexdomitor. So again, right forelimb, white lead, left forelimb, black lead, left hind limb, red lead.
This is a demonstration of a normal ECG waveform. The initial wave is the P wave, which represents atrial depolarization. In a normal ECG, the P wave precedes the QRS complex. It looks like a small bump upwards from the baseline. Next follows the PR intervals. In this step, you should measure the interval from where the P wave begins until the beginning of the QRS complex. You will also want to evaluate if PR intervals are constant or varying across the ECG strip. Followed by the PR intervals, there is the QRS complex. Because of the larger tissue mass, the QRS complex is larger than the P wave, while the prototypical QRS complex consists of 3 wave components. 1 or 2 of these components may be missing. In this step, measure the QRS interval from the end of the PR interval to the end of the S wave. The T wave indicates the repolarization of the ventricles. It is a slightly asymmetrical waveform that follows after a pause the QRS complex. Take note of T waves that have a downward or negative deflection, or of T waves with a tall pointed peak. Let's demonstrate this one more time. Followed by the T wave is the U wave. The U wave is a small upright rounded bump. When observed, it follows a T wave. The QT interval represents a time of ventricular activity, including both depolarization and repolarization. It is measured from the beginning of the QRS complex to the end of the T wave. The ST segment represents the early part of ventricular repolarization. The ST segment is the line that from the end of the QRS complex to the beginning of the T wave. Normally, the ST segment is flat relative to the baseline. Please note that any form of patient movement will distort the interpretation.
I have a patient that is under anesthesia, or theoretically one that is undergoing CPR, and I have her intubated. I'm going to attach our capnometer. This is a mainstream capnometer, which means that it attaches between the endotracheal tube and the breathing circuit, and it's going to take that reading right here. All I'm going to do is briefly disconnect, attach here and here. Now, each time Astra inhales or exhales, we're going to get a reading that is going to reflect the amount of carbon dioxide that we're inhaling and exhaling. So when we come over to our monitor here, this monitor is really nice because it's going to give us an example of a normal capnogram that we can compare to our patient here. So Astra has a respiration rate of 10, an in CO2 or an inhaled carbon dioxide of 0, which is exactly where it should be, and an exhaled carbon dioxide or end tidal of 44, which is really good. Our patient under anesthesia should usually fall between 35 and 45. If you had a patient that you were doing CPR with, this is going to be much lower than that. You should be achieving at least a 10 end tidal, and again maintaining a 0 in. But for better outcomes, you really should be getting up to about a 20 end tidal CO2. If you're not hitting that 20, you should be tweaking how you're performing your compressions, because although this is telling us about the amount of carbon dioxide we're inhaling and exhaling, that is going to be a direct relation to how well our patient is perfused and how her circulation is. The other really interesting and important thing about our capnogram is that we are generally going to see the very first sign of a return of spontaneous circulation reflected in our end tidal. So we'll have a patient that we're hopefully doing really good compressions on start around a 20. If we suddenly spike to a 35 or a 45, that may be our very first sign that our patient has started that return of spontaneous circulation, or circulating on their own and not necessarily needing us to do it for them. That's it.
When measuring SpO2, we are measuring the oxygen concentration in the peripheral bloodstream that allows us to get an idea of how well that PET is oxygenating. There are multiple places in which we can attach the SpO2. One is on the mucous membrane, on the upper or lower lip. Another is on the tongue, the ear. In male dogs, it can be done on the penis or prepuce, and on female dogs, it can be done on the vulva. You're looking for an area of high concentration of capillaries to the surface of the skin. Other areas that you can do it are in between paw pads, if it is feasible and the PET is not too pigmented. On this patient, because of her pigmentation in her oral cavity, we will be doing it on her ear.